So I think there's some take-home lessons. Let me tell you what I think the take-home lessons are. You can clearly, immune-based doublets are better than single-agent TKI across the board. And we can dive into the IMDC risk groups if you want, but let's just focus on ITT first. So in an ITT population, an immune-based doublet has less early PD, higher response rates, longer PFS, and better survival. That'd be, for me, take-home number one. For the OS hazard ratios, the IO-TKI regimen started very low and then have sort of crept up over time. Whereas the data that we saw at ASCO for the Ipi-Nivo hazard ratio has been almost identical, basically 0.7 plus or minus a couple hundredths here or there, almost identical. And I think one of the strengths of Ipi-Nivo, both as a regimen and a data set, is consistency and durability of response. Although I will say, if you look at the PFS curve, we both know there's a lot of censoring that happens on those curves, especially as you get to the tail.
About that.
I know you get upset, but the number, it doesn't level off. It still goes down a few percentage, even as you get to year 5 and 6 and 7 and 8 and now 9. So, and it's important because if I'm a patient,
we're curing some patients.
We're curing some patients, that's important. But you can also have, I guess, I don't know if you call them late relapses, late progressors. You know, and I've seen that in clinic, right, where people have been on for 5 years, et cetera, and you know, so the curve isn't completely flat.
But you lose some patients early on with Ipi-Nivo. You don't get control of everyone.
Correct.
Progression of disease occurs,
yes.
And not everyone sequences therapy. So it swings and roundabouts.
It swings and roundabouts, yes. Yeah.